Hi, it's Dr. Nick Tulo, and I hope this is coming over because I think I've done everything right. This is my 5th live stream, and whoever's out there watching, thank you so much for joining me. It's Saturday morning in New Jersey, and got a very interesting case to present. And I think you'll enjoy it because it kind of had me thinking for a little while. So, this was a patient who was actually 92 years old, but in very good shape, with lung disease, chronic lung disease, and she got admitted with pneumonia. And she was on the cardiac unit, and of course they were monitoring her, but she suddenly started to have a lot of irregular rhythms, a lot of premature beats. And the nurses brought some strips over, and they were trying to figure out what it is. So I thought I would share these strips with you and discuss how you figure out whether they are what the nurses thought were premature atrial contractions. So let's take a look at the strips here. Okay, so here's my, we're going to get to the strips. And here is the first one. And what you see is just lead 2 here. And I actually initially saw that it was clearly irregular, but there seemed to be a little bit of a pattern to it. Oh, it looks like we have someone from Egypt watching. Well, that's wonderful. Wow. I'm impressed. So, you know what? I do these videos on ecgacademy.com, and I have people subscribe from all over the world. And I must say, it's such a thrill to have cardiologists and nurses and students literally from virtually every country imaginable find my videos and enjoy my style of teaching. So thank you, and I appreciate your being there. So here's the strip, and it's clearly irregular, but you look at it and you try to figure out if there's some kind of a pattern to it. And what I thought I found is that there seemed to be premature beats. So you had this as a premature beat, and then you had kind of a normal looking beat and a normal looking beat, and then a premature beat, and then a normal looking beat, and premature. But we're trying to look for P waves. And in this particular lead, it was really hard to see them. So I thought perhaps it might have been sinus rhythm with a lot of PACs, because when you look at these QRS complexes, they look virtually identical to the underlying ones. But I thought I would get a pair of calipers and just see what we can measure out. So I grabbed a pair of calipers and I brought it down to the strip, and I kind of set it for the timing of these beats that I thought were normal. And you can see that this times out exactly. Those 2 beats are normal, and then these 2 beats are normal as well. So it seemed to be a regular rhythm with what perhaps was atrial trigeminy, although I couldn't see the P waves. Why not? Well, we know that P waves have a direction. P waves usually start from the high right atrium and move downwards and towards the patient's left. But if you're monitoring, sorry, let me just draw on something. So if you have an atrial rhythm that, let's just say, is heading down and towards the patient's left, and you're monitoring lead 2, you expect, which is going from the right arm to the left leg, you expect to see nice juicy P waves because those P waves are headed in the direction of lead 2. But sometimes you might have atrial rhythms that are going in a different direction. And so you may have P waves that perhaps are going in a different direction from lead 2, and then you might not see them because they're isoelectric in that particular lead. So I wasn't sure if these P waves are isoelectric or if they were PACs. So what should the first thing you do if you're kind of confused about it? You'd order a 12 lead. But I was like, well, let me just measure a little bit more, because I thought it was kind of interesting that these premature beats seem to have a different coupling interval each time. So this premature beat was sort of widely coupled, and then this premature beat came in a little bit earlier, and then this premature beat came in a little bit wider. So when I took the calipers and kind of measured out, where's my, looks like my mouse isn't working. So when I took these calipers and I took these two normal beats, right? And if I brought this over and just kind of made like a little mark there, and then brought the calipers over again, I found that the beats came on time. Isn't that interesting? And let's see if it's consistent. So here's that premature beat that's a little bit later now. We'll make a little mark just to see what's the timing of the next beat, and then move the calipers over. And it was just like, wow. Well, you know, there's different kinds of premature beats, and after a premature beat, we generally see some kind of a pause. And sometimes we call this a compensatory pause because it's just how much time it takes for the sinus beat to occur, because the sinus node has to kind of like catch up with itself. But in this case, we have what's known as a fully compensatory pause, where the next sinus beat occurs exactly on time. That's kind of unusual for a PAC. Why is that? Because if there's a P wave here that occurred in front of this premature beat, let's presume it's a PAC, then this beat usually resets the sinus node, and so it throws the sinus node timing off a little bit, so that the next sinus beat usually does not occur precisely on time. It usually occurs either a little bit sooner because the sinus node got reset, or it comes a little bit later because that premature beat gets into the sinus node and suppresses it. You know how overdrive suppression can sometimes cause sinus pauses after premature beats, especially if the patient has some degree of sick sinus syndrome. So I was like, wow, look at that. These beats come on time. This is known as a fully compensatory pause. And what does that usually mean when you have fully compensatory pauses? Well, it means that the sinus node didn't see the beat. It means that the sinus node did not see the premature beat, and the next sinus beat comes on time. But when do we usually see that? I mean, you guys who are experienced should kind of know that it's usually when you have a PVC, a ventricular premature beat, because most PVCs don't get up the don't get up the AV node back to the atrium. So the sinus node doesn't see the PVC, and the next sinus beat occurs on time. So I was like, there's no P waves. I can't figure out what's happening. Are these PACs or what? So let's get a 12 lead. Okay, so now let me show you what the 12 lead looked like, and I think you'll be very surprised. Just get the 12 lead up here. Okay, so this was the 12 lead. And so you can still see what's happening here is that you have premature beats and then two normal beats and a premature beat and a couple of normal beats and a premature beat. So there's still sort of a trigeminal rhythm going on. But when you look at those premature beats, oh, look at that. In V1, V1 has all the answers. First of all, there's a nice big juicy P wave in front of those, what we were thinking were normal beats. So that establishes that the P wave in lead 2 was isoelectric and was not showing up on this tracing. But there is clearly a P wave in front of those sort of normalish looking beats. But now here's the premature beat, and isn't that interesting? The morphology in V1, V2 is different than the conducted beats. It's up. It almost looks kind of like a right bundle branch blockish looking thing. And when you look at all the other leads, yeah, okay, there's a little bit of difference. Look at this in lead 3. You can see the QRS is a little bit larger. Lead 2, it's almost the same. Lead 1, the axis is now going away from lead 1. Isn't that interesting? These beats have a right axis deviation because it's going away from lead 1. So you've got this right bundle-ish looking right axis deviation extra beat, and you start to wonder, are these really PACs? Could this be some weird aberrancy, right? Like a right bundle, left posterior hemiblock aberrancy. But here you see these big juicy P waves in V1, and you don't see a P wave in front of those beats in V1, V2. If you look at any of these leads, you really don't see the P wave that is the premature atrial beat. But here's something that was very interesting. Look at the onset of the QRS complex in V1. It almost looks like a slurred upstroke. Now, don't get excited, all right? This is not going to wind up being WPW, but this slurred upstroke really almost kind of didn't belong to that QRS complex. And it was timed in such a way that I was like, I wonder if that's the P wave. Could that be the P wave? So let's take a pair of calipers and see what we have. I set this caliper up. Oops. Let me move the calipers and not the graphic. I set these calipers up. I'll turn the graphic off for a second. So now I set these calipers up from this P wave here. Just put a new layer. And so here's the P wave that we were talking about. And here's this funny little bump on top of at the beginning of the QRS complex. And when I move the calipers over, darn it, got to get these layers straight. When I move these calipers over, look what happens. You have, let me just kind of like fine tune it. This P wave is, in fact, at the same rate as the bump. So what do you think is happening? There's a sinus P wave right here. And so the atrial rate is, it's about 70 or 65 or something like that. So you have a P here and a normal sinus P here and a P wave here. But those are the only leads that you can see the P waves, because all the other leads, the P waves are really, really tiny. You don't see P waves anywhere else. But this establishes the fact that these beats are actually PVCs. What? They don't look like PVCs. They're narrow, and they kind of almost sort of look like the normal beat. But they are, because look, it occurs simultaneously with the sinus P wave. So it didn't come from that P wave. There's no P in front of it. It arose from the ventricle. You had the normal beat comes down, a normal beat comes down, and then you have a PVC that occurs at the same moment as the sinus P wave. That's why the next sinus P wave occurs on time. That's why there's a fully compensatory pause, because these weird looking PVCs, which are very narrow and look almost exactly the same as the conducted beats, well, they didn't affect the sinus node. And that's how you can tell, because the next sinus beat is perfectly on time and it's fully compensatory. But you couldn't figure that out unless you actually got the 12 lead. So the other thing is, where do you think these PVCs are coming from? Because they look so weird. Well, they're very narrow, so that usually means that they're coming from somewhere in the conduction system. And if you had to guess, since it kind of goes sort of up in V1 and it's got a sort of a right axis deviation that's consistent with a left posterior hemiblock, after all, look at AVR. AVR is isoelectric. If AVR is isoelectric, what does that make the axis? So here's AVR, which is 30 degrees above the horizontal. That means the axis of these PVCs, since it's going away from lead 1, makes it plus 120. So plus 120 is consistent with a left posterior hemiblock. So if you have a beat that looks like a right bundle left posterior hemiblock, where do you think it's coming from? The left anterior hemifascicle, right? Now this is a complex idea. Let me just run it by you again. Okay, so let me draw a little heart here. And remember that you've got mainly 3 branches in the conduction system. You've got a very thin right bundle branch that goes down to the right side. And then the left bundle is much larger. but it splits into a thin left anterior hemifascicle and a much heavier left posterior hemifascicle. Well, if a beat arises from the left anterior hemifascicle, let's say right over here, what happens is it hits that part of the heart more rapidly, but it has to go back up a short distance, get to the His bundle, and then turn around and go down the right bundle and the left posterior hemifascicle. So what happens is the right bundle branch and the left posterior hemifascicle get the signal a little bit later than the anterolateral part of the heart. So it looks like those two fascicles are delayed, and that's what gives you the appearance of a right bundle left posterior hemiblock when the premature beat arises from the left anterior hemifascicle. Isn't that fascinating? It's like, wow, how cool. If this is kind of like really exciting to you, well, then make sure you subscribe to my YouTube channel, because I'm going to try to do these clinical live streams every Saturday, and maybe I can get them more frequently if a lot of people sign up and watch it live. So my friend from Egypt asks if I could explain the P wave axis in this case. So it's kind of, the P wave is looks like it's arising from, first of all, the P waves in the limb leads are very, very small. So this is a 92-year-old woman whose atria are probably kind of fibrosed, and I think that's why the P wave size is so small in most of these leads. I think in lead 1, you could probably see just a little bit of a deflection here, and in AVL, you have a little bit of a positive deflection. So it's probably heading up towards the left arm, but it's the P wave is so small, it's really hard to say exactly what the P wave axis is. But what I wanted you to keep in mind is that sometimes P waves are much smaller in certain leads because the P waves are going perpendicular to that particular axis. So the important thing is that you have to, the only way to see the P waves in this particular patient is to do the 12 lead, because it's V1 and V2 are like right over the right atrium, and that often gives you a very large P wave deflection. The fact that it's markedly positive in V1 makes you think that it's headed towards the right side, so maybe the P waves are actually rising from, not from necessarily from the sinus node, but someplace else. So it's an interesting question, and I appreciate that. So it's, someone from the Czech Republic, thank you. It's so exciting to be speaking to people all over the world, and I hope that you can share my YouTube channel with your friends and colleagues. So it's ECG Doc if you'd like to subscribe. There is a link in the description down below this video. And if you enjoy this content, or if you'd like to learn more about the advanced physiologic approach to arrhythmias and electrocardiograms, then check out my website, which is ecgacademy.com. And I have a whole entire course from beginning to end for basic as well as advanced users to, gain more of a physiologic approach, because I'm an electrophysiologist, and I think in terms of what the conduction system is doing, because I think teaching that part of arrhythmias is just so much more useful and a better way of learning how to approach these kinds of complex issues. As far as the patient is concerned, I think what you have to realize is this patient was asymptomatic. She has normal left ventricular function on an echo. She came in with pneumonia, so was having issues with mild hypoxemia at times, was on oxygen. And these extra beats are so narrow that they're activating the ventricle in a very efficient manner because it's coming from the conduction system itself. So most of the time, these beats, which are sort of not exactly super premature, where conducting, you can actually feel the patient's pulse was a little bit irregular, but she didn't notice them. So in fact, when you have when you have this type of minor arrhythmia, premature beats, and the patient's not symptomatic, we usually don't try to treat them because, after all, any medication that we use is going to have the potential for side effects, including beta blockers or verapamil or certainly antiarrhythmic drugs. So we chose not to treat these beats, and in fact, they came and went, but were not clinically significant because she had no symptoms. I do see a couple of comments, so I'd like to share them with everybody. Is there any new projects in the pipeline for ECG Academy Advanced courses? Absolutely. You know, between these live streams and keeping up with the chalk talks and my clinical practice, since I am a practicing electrophysiologist, it's been difficult, but my next section that I'm working on is the WPW section. You know, the funny thing is that, at least in the US, Wolff Parkinson White is a very rare occurrence now because we've been doing catheter ablation for WPW since the late 1980s. And so I like to say that wolves are an endangered species, because I think the only EP docs who see them are the pediatric EP docs. When someone happens to walk into a doctor's office with palpitations, you know, a 17-year-old is going to have a delta wave, and they'll wind up getting ablated before they even become an adult. But now and then we do see some, and I'm going to be talking about WPW in the next advanced section. So stay tuned. I'm going to try to spend more time doing that. But just to show you, my assistant producer wanted me to make a list of everything that I had to do to make sure the live stream came over. And this is the list. It's like 12 different steps. It's crazy. It's not just pressing go and talking. But I do appreciate there have been a whole number of comments. And the advanced course, by the way, also includes a lot of lectures that I've been giving. I just did a grand rounds for the residents at my hospital on atrial fibrillation. So that's like a 1-hour lecture that's in the advanced section. And you can watch that because that's very clinical as well. These live streams are supposed to bring a clinical angle to the complex electrocardiograms. And I hope they serve the purpose. I really hope that you enjoy hearing them on a Saturday morning. And until next time, I think I'll sign off. I appreciate all of you who took the time to be part of this. And until next week, this is Dr. Nick Tulo. Thanks for watching.